Hi, so this is just a quick video. I hope you can see this clearly. I'm just trying this video out and I've just got a few minutes, but in a few minutes, you can learn a lot. I promise you maximum value. So this is the basics of any ECG. There are some normal waves. You have the P wave, you have a Q wave, you have, oh, I've not talked about an R wave, yes. There is the R wave as well, and then there's the S wave and the T wave. But in another section, I can be talking about the J wave, the U wave, and other types of waves that you will find, but not necessarily in a normal ECG. But that would definitely, those other ways will help you know when an ECG is normal or abnormal. With the P wave, it's very simple. This is your P wave here. It's the beginning. It signifies, depolarization of the atrium. Depolarization just means electrical shock and current is passing through the atrium. And there will be other lectures, but just go with this flow. So if you see an ECG, each wave or each complete, transmission of electricity is, each bit is what you have the PQRST, and this is what you have as a single bit. So this is the P wave, and this P wave, like I said, is when the electricity passes from the pacemaker, which is a sinoatrial node, through the atrium. It's trying to get to the ventricles and other part of the heart, but it goes through the atrium first. And I want to make this short and sweet. There are other videos and there's a full course if you're interested. But if it is tall, right, and peaked, you have right atrial enlargement. If it is wide and notched, right? If it is wide and notched, you have left atrial enlargement. And there's a reason for this. When electricity passes, sinoatrial node is located in the right atrium. And so if it's tall and peaked, it could be that the atrium is just way too big. But I promised value in a few minutes, so let's move on. Then there is the Q wave. The Q wave, in many times, isn't a problem, but it can be a problem in the sense that it can signify that an infarction has occurred. And when I mean infarction, death to the heart cells has occurred. And as you can find, this Q wave should be short, short and concise, but it should not be more than one small box, which is usually 0.04 seconds, right? But if it is greater than one small box, or it is wide, becoming very prominent, or it's more than 25% of your R wave. So this should not be, the Q wave depth should not be up to should not be more than 1/4 of your R wave. And if that is happening, then what you have is that it is a pathological Q wave. But note that this could be normal in AVR 3 or V1. It could also be normal in early repolarization, and you could have an isolated and tiny Q wave in 1 or AVL. It takes some practice, but knowing the basics help, because then you can say, oh, well, given this patient's history, they've come in with chest pain for maybe 4 or 5 days. They're not currently in pain, but the pain sounded cardiac, and you're seeing an ECG with a Q wave, that's a bit wide, more than one square or more than 25% in V1 to V3, then your antennas are up and saying, what is really going on here. And then S wave. So this is your P, this is your Q, this is your R. Now, I didn't talk about your R wave, but I will talk about it. I will do another training on that. I don't know why I omitted that. But your R wave is what is deflected up and your S wave goes down. Now, the S wave is interesting because, if it is deep in V6, it will be a right bundle branch block or a RVH. We know that the right bundle branch block, for example, we talk about the marrow, we talk about the marrow William. And what we just mean, there's a lot of technology technique to it and understanding how the heart works. But basically, for the sake of this short presentation, if it's becoming deep in V6, right? You want to talk about, so problems with the S wave is that it could become deep. You could be talking about an LVH. We know we talk about S in V1, R in V6 for LVH. If S is deep in V6, it could be an RVH. Then we talk about the right bundle branch block, we talk about the RSR pattern. These are other lectures, but don't get overwhelmed. Just know that the problems with the S waves becoming a bit too deep, either in V1 or V6, could mean that hypertrophy of some sort is going on. When do you have hypertrophy? You have hypertrophy when there's a big heart, right? Or there's a big, there's a problem with the structure of the heart. It has thickened from maybe doing too much work, from hypertension or from other problems, right? Or impulses are not just passing through because maybe the heart is dead. That part of the heart muscle is becoming dead or stiff. So basically, also you want to talk about your S wave when you talk about your S1, Q3, T3. Remember your PE. Now, for your T wave, problems with your T waves are very interesting and how will I say they are very important because they could signify injury to the heart. Hyperacute T waves, you have your T waves in welling. If it's biphasic, you're talking type A in 25% of patients. In the other 75%, it might not be biphasic. You're talking De Winters. De Winters is upsloping depression of your T wave. Hypokalemia, you could have your sine wave, your T wave forming like a sine wave pattern. Hypokalemia, you have flat T waves. As promised, value in minutes. I hope you enjoyed this. Please let me know.